Okay. So I always hate to have an end to break, but we got to go sometime, right? Otherwise, we've got a lot of stuff to get through. So right now, I'm going to warn you that this was kind of like the easing into it. Now we're going to get a little bit more critical care and a little little less country, a little bit more rock and roll, as they say, right? So this is an anesthesiologist, all geared up to intubate in full gear. You can see the endotracheal tube in his hands. So things are changing. I do want to, I think if these videos show, then we will be on it. If they don't show, let's see. There we go. Okay, let's do this one. Here is this is a video, and I think this will play. Oh, let's see, open, allow, and continue. This is actually an extubation of someone who is a COVID patient. So you can see what they're doing is they're using new technology to cover the face to prevent aerosolization of secretion, right? There's two times you have to worry about aerosolization. Once when you intubate, and once when you extubate. So you can see here, this is a case probably in an OR or in an ICU where they're extubating someone. Everybody's in full gear. Everybody's got a face mask and masks, right? And the idea is to extubate the patient so that nobody gets exposed to secretion. Okay, the tube is out, we're all set, and you're done, okay? So I'm going to show you the next one here. I'm going to see if this works. This is an intubation. So we're intubating, what we're doing is we're masking the patient. I get a code, right? Before you intubate, you actually can isolate the patient in a hood, if you will, right?
Lasciando una parte di telo più lunga. Allora, materiale pronto prima dell'arrivo del paziente in sala.
So you can actually put a mask underneath, and this is what we're going to do later. We're going to try this with one of these ventilator bags. Okay? We're going to see how this works. We're not going to put anybody in it, okay? But we're going to show you how it works. So you can actually proceed with an intubation after you secure the airway while managing the aerosol.
Ok, va in montaggio, assemblaggio del tubo.
So I'm going to stop that. I'm going to move on, and because I think this is all pretty important here, but I don't want to belabor too much. But again, being creative. Remember, I talked to you at the beginning about new ideas. Well, you're trying to maintain the sort of not the sterility, but sort of the patency of the surroundings so that other people don't get exposed, okay? So if you can control the aerosolization of secretions, these bags here are fantastic for that. You can see through them. And in fact, if you were going to run a code and throw one of these over a patient, you could bag the patient through the bag, okay? And you could actually manage the airway all the way to your destination if you can't get the patient intubated where they are, okay? So just last week, there was a code here. We had a situation where folks responded to a code, and they actually ended up bagging the patient all the way until they got to one of the ICUs. Turned out the patient was COVID positive or suspected COVID positive. The fact is that that's a problem, okay? So you don't want to be in that situation where you're exposing everybody to the potential virus, okay? A big deal, okay? So again, protective equipment, very important. I showed you the videos already. So decontamination, we talked a little bit about decontamination. Now using the UV lights, okay, getting the UV lights into the room, big deal in terms of potentially sterilizing the room. We used to use them only for Clostridium difficile. Now we're using them for everything else. And some folks are talking about gamma ray sterilization, especially of re-sterilizing masks. So that's another important thing. So I'm going to talk about access. Let's start getting into critical care now. Okay, we talked a little bit about theory. Yes, ma'am. Yeah, so technically speaking, you should be, right? So technically speaking, you should be wearing booties probably, you should be wearing hair protection. I think it all depends a little bit. I mean, if you are on a ventilator, then you're in a closed circuit, and the ventilator circuit is it has a HEPA filter in it, okay? On the other hand, if you're in a situation where you're about to manage somebody with secretions, I think, folks in my ICU will tell you that I've always been putting on a hairnet. It'd be nice to put on booties, but again, maybe just leave the shoes at the door when you get home. Depends on what you have available. But again, yeah, it's a good idea. Okay. So any other questions? Yeah, please. I mean, just hand up if I see you. If I don't see you, then wave around a little bit. I respond to motion sometimes a little bit better. Yes, ma'am. I don't know. I'm not on the policy setting, and like I was telling people, I usually only read emails once a week, and usually only the top 3. So it's kind of, I'm usually not plugged into all this stuff completely. This is more about theory than it is about application and policy and stuff like that, okay? All righty, so access. So access is really important. Some people will say access comes first, okay? Because when you talk about ABCs of resuscitation, if you don't have access, it's really hard to proceed with a resuscitation. One of the first things you're going to need is something to carry medications, right? So you need to carry medications into the patient. If you're going to intubate them, you need to carry fluids into the patient. You're probably going to have to draw some blood, okay? So getting all this stuff is very, very important. It's essential for the acute management. So sometimes a peripheral IV is just fine. You don't always need a central line. So again, it's very, very situation dependent. But there are a couple of different kinds of central lines. One's a classic central line, which is a triple lumen catheter or an introducer catheter, and the other one's a PICC catheter, which is a peripherally inserted central catheter. And then finally, we have an intraosseous line, which is almost, in fact, as good as a central line. So why do you need access? Sometimes people have poor access. You have people who've had prior chemotherapy, have had prior veins, or they just kind of have they're on steroids, they have friable veins, you can't get an IV into them, or they're hypovolemic. And if they're dry and there's not enough filling pressure in the venous system, it's going to be hard to find a peripheral vein. Hospital administration of hypertonic saline or hypertonic medications, bicarb is one of these, okay? Venous irritants, things that irritate the venous system. Vasoactive medications, rapid transfusion monitoring, and of course getting more advanced stuff in there as well. So again, how do we actually get access to the central circulation? Well, the internal jugular vein is probably the most common way that we get access. Why do we use it? And why do we use that? It's usually where most people have gotten their training. And later this afternoon, we're going to go ahead and we're going to have volunteers lay down and show us what their IJ looks like, okay? Because we're going to have an ultrasound and people can practice finding it. Once you find it, it's relatively easy to poke it, okay? Subclavian veins, another one. Femoral vein, we don't like the femoral vein so much because potentially it's easy to access in most people, but again, it tends to get dirty if they're soiling the bed, for example. Some folks, have a relatively poor hygiene. You're going through intratriginous folds. Whenever you're going through an intratriginous fold, whether it's in the axilla or the groin, there's always potential for fungal contamination or something like that. And of course, a PICC catheter or central venous catheter. This is what it looks like. I bet most people have seen one. Okay, pros of the IJ. Why do we use the IJ? Well, it's accessible. On most people, it's very, very easily cannulated, okay? It's also compressible. So if somebody comes in and they happen to have an INR of 20, okay, you can still put an IJ in, okay? And this is, I'm not kidding. I mean, when I worked in Pittsburgh and I did liver transplants, we used to double cannulate the IJ. People had INRs of 20, okay? And that was before the days of ultrasound. The thing is, sometimes we would miss, okay? And then we would have a big hematoma. But you could compress it for a while, and chances are it would go down. It's ease of visualization. It's very easily visualized with ultrasound. It's harder to visualize the subclavian. And some folks can do it, but it's a little harder to find the subclavian with an ultrasound. And again, I put compressibility twice, but again, relatively low pneumothorax rate. I think this was one of the slides I made at midnight. So the thing is that relatively low pneumothorax rate because you're fairly far away from the lung. However, remember, especially in COPDers, there's a part of the lung called the cupula, okay, which comes above the clavicle, and it actually anchors here with, sort of some soft tissue. And those folks who have chronic hyperexpansion in their lungs are very vulnerable for you to hit the cupula if you miss the IJ on the first shot or if the needle goes a little bit too far. So it's still possible to get a pneumothorax in an IJ. The cons, it's sitting right next to the carotid artery. If the patient's coagulopathic and you hit the artery, if you hit it with the finder needle, not such a big deal. But you hit it with the big needle, or you get the introducer in there, that is a big deal. So you have to be cognizant of some of the structures that are in that triangle, right? The anterior cervical triangle. Again, the carotid injury, contamination, it's kind of a bad place to have one for a long time. Guys grow beards, okay? So the beards grow all around the line if the catheter has been in there for 2, 3, 4 days, okay? So now you've got that, sebum and the secretions of saliva going in there, and you've got this perfect nidus for a line infection. So maybe not the best place for a long-term line, so you've got to think about that as well. And it can be positional if you're moving patients around. Dr. Whitbeck's nodding his head, so he's always doing spine surgery on patients. They're turning the neck, and they turn the neck, and sometimes it doesn't infuse very well, okay? So again, it can be a little bit difficult. This is the anatomy of the triangles in the neck. And so what happens here is that you can see the two heads of the sternocleidomastoid, the sternal head and the clavicular head. And right here, as you see these two bellies, sort of the muscle divide, if you poke in there and you follow this along, you are almost always going to hit the internal jugular vein. And those of us like me who are old enough to have trained before we even knew about ultrasound machines, unfortunately, it's true, but we used to do this absolutely blind on a regular basis. Now we're going to show you how it's almost foolproof, and you can, when you see the vein, you identify the vein, you can go ahead and you cannulate the vein, and almost every step of the way, you know you're in the vein when you see your finder needle, and even sometimes you can identify your wire in there. Underneath here is the subclavian vein, which is underneath the clavicle, which is the other approach, and we'll talk about that in a little bit. But again, this is kind of, here right behind the subclavian is the subclavian artery, and I think right behind the subclavian artery is pleura. So again, this is a kind of an area where there's a lot of stuff that happens. I think anybody who puts in a central line should probably know how to put a chest tube in, or at least decompress the chest, okay? So if you get an inadvertent pneumothorax, when you're putting a line in, recognized complication of a central line is a pneumothorax, you should be prepared to treat the pneumothorax or know who to call to help you get out of that situation. And if there are positive pressure ventilation on a PEEP of 20, then that is potentially a rapidly deteriorating situation. Again, so this is the triangle here. It's almost impossible to miss the vein. However, in patients who are dry, who are intravascularly depleted, this collapses so much faster than the subclavian. The subclavian is kind of tethered a little bit by some soft tissue, and the subclavian stays open much, much longer than either the IJ or the femoral. So it's a lot easier to cannulate in trauma patients who are hypovolemic. But once again, it is rapidly accessible, and sometimes you can even do this while compressions are going on at a code sometimes. So again, we use an ultrasound machine to identify this, and you'll all have a chance to see exactly how this works in real time. But what we do is we basically put the ultrasound probe on the neck, and as we do that, we identify the structures, and there's usually a carotid artery sitting right behind or right next to the vein, and depends a little bit on what kind of angle of approach you have. And then that way you can actually make it so that the position might be safer depending on which angle of approach you use, less likely to go through the back wall. If you go through the back wall here, you just go into soft tissue. But if you were coming in here, for example, you might go through a back wall of a relatively collapsed IJ and hit the artery. So once again, you have the opportunity not only to define the vein and define the anatomy, but you also have a real opportunity to define the best angle of approach. So there's a lot of things that you can do with an ultrasound machine, and we'll get to play with that shortly after lunch. So again, you go ahead and you numb up the area, and you use the ultrasound machine. This is the IJ. This is the IJ. And how do you know it's the IJ? Because it's compressible. Okay, so you push on it, and this one, of course, is probably pulsing. But I will tell you, we see a lot of IJs that pulse. It just works out that way. So don't use that as your guide. Sometimes we just see the carotid not pulse, right, which is another problem. But the thing is that, the truth is, so pulsatility is not necessarily what you want to use. You want to use compressibility. And when you compress the artery, because it's still so thick-walled, you actually can see the walls, sort of compressing down upon themselves if you were to push hard enough. whereas the vein has such thin walls that you don't see the walls compressing down upon themselves. The other thing you can do with the ultrasound is to find that sometimes people who have multiple prior sticks and have had lines before, they're actually thrombosed. Okay, so sometimes you can actually see the clot sitting in the IJ. So you have to be careful because that's something you may not want to dislodge. So if you see a clot on the right IJ approach, you may want to go over to the left side, just visualize the left side, because maybe they had a prior dialysis catheter, or they were in the hospital for a little while. So these are things that you can use. It's the tools that you have available to you that you can make the best use of as you're moving along, okay? So again, you can visualize your needle. It never looks quite as good as that, but here it is. Okay, so once again, it's your angle of approach. Now, these are lymph nodes. You hit that, you probably go through the backside, not cause a lot of problems. But again, you want to make sure that you're not coming in at this kind of an approach where you're going through the back wall and potentially hitting the carotid artery, because that happens especially in patients who are hypovolemic. If they've been coming in with diarrhea, they've had a bowel prep, if they're toxic and they haven't been able to eat or drink for a couple of days, they are going to be intravascular volume depleted, otherwise known as dry. So what happens in those patients, you have to be very careful not to go through the back wall. We use something called the Seldinger technique. The Seldinger technique is just theory. It's very interesting. But what happens is once you get an access with a hollow bore needle into a vessel, whether it be an arterial vessel or a venous vessel, you can then insert a guide wire through that hollow bore needle, get yourself into the intravascular space, and then you can do whatever you want. You can move back and forth as different kinds of catheters, different kinds of needles, whatever you want to do. And this is commonly used in vascular surgery and also in radiology, for example. So you get this hollow bore needle in, you move your guide wire through the hollow bore, you've got your guide wire in, then you place a catheter over that, and the idea is to pull back the guide wire. Okay, so once again, I'm not going to spend a lot of time on this because actually I have a few slides here that are probably redundant. But what I'm going to tell you is that the most important thing here is to never lose control of the wire. Okay, that is the important part of the technique. Do not ever lose control of the wire. If you push the wire in too far, you don't have your finger on the wire. If for some reason something changes, you're going to have a foreign body embolism. Okay, so you're going to actually lose the wire, and it's hard to get it out. Once it disappears underneath the skin, you really need someone to come in, and vascular surgery or surgery needs to extract that, or IR needs to extract that wire. So one hand always on the wire, two fingers always on the wire. A little bit of wire always protruding so you know that it's out. Do not ever lose control of the guide wire, okay? Really, that's if you remember nothing else about central lines, that's the most important thing you could possibly ever remember. So again, this is it. You access, you go through the wire, go through the needle. You don't project so well. The other slides were better. But again, you now have usually we use a dilator. You have to make, at one point, you're going to have to make a skin nick. Usually what happens is if you make the skin nick too big, it bleeds for a long time. So if you make the skin nick too small, then you sort of dissect the tissues, but sometimes you can also bend the wire. So it's sort of like, this one's a little too big, this one's a little too small, this one's just right. You have to kind of get it right. It's a little bit of experience. But usually what happens on the scalpel, which I think is in the number 11 blade, what happens is there's a little bit of an inflection point. If you go just to that inflection point, in most people, it's enough to be able to get into the tissues without having to have a lot of bleeding. And you can still spread the tissues a little bit, which is another way to minimize bleeding. Once you've cut into the vessel with something sharp, it'll bleed for quite a while. So this is the dilator. The dilator for the central triple lumen catheter is relatively small, but the dilator for the introducer catheter is much bigger. Okay, so they make big holes. Okay, again, things to think about. So again, then you have to pull the wire back out. Not pull the wire, pull the catheter out, leave the wire in there. You have to be careful when you pull this back that you leave enough wire inside the vessel so that what happens is you can then get back into the vessel. If you pull your wire back out while you're pulling your needle out, then you're going to lose access. It's the whole idea behind the Seldinger technique. So again, then you place your triple lumen catheter or whatever catheter you have. It could be an 8-point French or 9 French introducer or whatever. You get it in over as long as the guide wire is there. That's why we call it a guide wire, so that we can move it and guide the rest of the catheter into the intravascular space. And the most important thing after that is to take the wire out and make sure that the wire is retrieved, okay? When I was younger, I used to obsess over this. I used to keep it around forever so I could visually remember that I pulled it out. It's very, very important that that guide wire gets out. So again, caveats, sometimes patients thrashing around, okay, that could be a big deal. This is where you need like a really good set of assistants, kind of holding the patient's neck in position, or, keeping your hands from pulling up and grabbing this thing. You got to keep the head of the bed flat, or almost flat. Why do you think we don't put central lines in with patients sitting up? Air embolism, right, okay, there you go, you said it. So air embolism, so what happens is the heart, okay, has something called the right atrium. The right atrium is kind of what we call the phlebostatic axis, okay? It's kind of like gets to zero pressure, okay, when you breathe. So when your intrathoracic pressure goes subatmospheric, then the pressure in your atrium actually goes partially subatmospheric, so you create a vacuum. If you've got something open into the right atrium, whether it be the dural venous sinus during a sitting craniotomy, or the neck veins when they're doing a cervical laminectomy, and patients are breathing spontaneously, they can suck air. In fact, this happens in OB. Anybody here from OBGYN? What happens is when they exteriorize the uterus at the end of a C-section, you can actually, patients complain of shortness of breath because the uterus is actually above the level of the right atrium. So while they're sewing the uterus closed, we, anesthesiologists have these little funny tools, and we can often watch the air bubbles go by, okay? So the fact is that this is really important. So head of bed flat or almost flat. Do not open the veins above the phlebostatic axis when the patient is breathing spontaneously, okay? Very important. And actually, the other truth is that if the patient's hypovolemic and you put them into Trendelenburg, i.e. head down position, you can actually use gravity to fill the veins a little bit, make it actually easier to find the vein. So there's a lot of reasons for doing this, okay? Local anesthesia will need to cover the suturing sites, okay? That's another one I probably did at 2 in the morning. But anyway, we'll cover suturing sites as well. Plasticity or absence, of a pulse or pulsatility is not a reliable sign. And then you have to make sure you aspirate all the air before flushing, okay? One of the first big malpractice cases I was ever involved with when I was still doing plaintiff work, I went down to North Carolina. We had a situation where they put a central venous catheter in someone. And what happened was they put a catheter in, and the person who was given the job of flushing the catheter did not aspirate the air out. It turned out that by accident, the catheter was actually in the arterial system. So it was a subclavian catheter that went into the subclavian artery. So what happened was, as soon as they flushed the catheter, the patient had mental status changes in pre-end. So they basically blacked out. So what did they do? They got a chest x-ray, showed the line in the aortic knob. Is that malpractice? No, it's not, okay? Why? Because it can happen, okay? Failing to recognize it, that's malpractice. Flushing the catheter full of air, malpractice. Then they go ahead and do a head CT, and the brain is full of air, okay? Always aspirate the air out first, okay? That's where the issue is. It's not a matter of everybody's going to hit the artery sometime. Everybody's going to malposition the artery sometimes. Everybody is going to go ahead and get a pneumothorax sometimes. Don't get too many of them, but the fact is, do not flush the catheter. Always aspirate every ounce of air out of that, even if it's venous, and you inject the air into the venous system, and that patient happens to have a PFO, okay, or something else, like a VSD, ASD, something like that. What happens is, now all of a sudden you've got a situation where the venous air is going to go into the left heart and potentially cause an air embolism to the patient's brain. So again, aspirate all the air out, and make sure that if you delegate that to someone, in this particular case in North Carolina, they had delegated it to someone who'd never done it before, make sure you delegate it to someone who understands that it's not just about flushing. It's about aspirating, okay? So very, very important, okay? So again, by the way, we settled that case. We didn't go to court. Anyway, aspirate all the air before flushing. Right, chest x-ray is considered to be customary. Most of the time, if you see it go in and you know roughly that you're in the right place and you aspirate all the blood out, you know that you're probably in the right place. But we always get one to rule out a pneumothorax, make sure it's not too deep. Where should the tip of the line be? Exactly. So it really should be just outside the atrium if possible, okay? So it should be in the central venous circulation at the junction of the superior vena cava and the atrium. If you have it in the atrium, it can tickle the atrium and cause arrhythmias. Subclavian vein, is more comfortable. It's a little bit easier. It's not potentially so positional. Less risk of carotid injury, but remember, you can still hit the subclavian artery. It's easier to keep clean. So when people are drooling out the side of their mouth, then what happens is, they're not drooling right onto the subclavian. So it's a little bit easier, okay? But most people have more experience doing an IJ, and at the same time, remember, we're using the tool, the ultrasound, to be able to maximize the safety and the efficiency of doing this line. So cause slightly higher pneumothorax risk. And it can be very difficult. If you have somebody who's obese and you have to sort of push really hard to find the clavicle, it's deep down in there somewhere, and your angle of approach is very difficult. And then what happens, same is true with kyphotic people or those who are rotated. Okay, so here you go, and you're going in directly underneath the clavicle, and you're pointing it right to the sternal notch. And so what happens is, so here's your angle of approach. You keep aspirating, and you should usually get it on the first try. A PICC catheter is a very, very useful tool. It's peripherally inserted, especially in non-emergent circumstances. You can get one of these in. The pros, you can use this for a long period of time. They're good for like weeks. You can send people home with PICC catheters in place. So 6 weeks, whereas a central line usually has a life of about maybe 5 to 7 days. So it's not going to be in there for very long, okay? Again, there's no risk of pneumothorax or arterial injury. It does have a risk of DVT, and the issue is one of length, because it's a very long catheter, right? It's a peripherally inserted central venous catheter. So these are the catheters, and this is where they are. They live in the central venous system. Okay, so this is what a PICC catheter looks like. Now we use something called a Sherlock when we place the catheter. We put this over the sternum, and what we do is we look for the maximum deflection of the P waves, and when the P waves get to be the highest, we actually know that the catheter is in good position. They don't even need a chest x-ray. Okay, so the Sherlock actually, not only are you using an ultrasound to place it, but you're using this EKG guidance. You do not even need a chest x-ray to verify placement. So how do you assist with central venous catheter placement? Having a person in the room who can really help you along makes a huge difference. First of all, somebody's checking allergies and sites. You also you have somebody who's your buddy looking to make sure you didn't accidentally contaminate yourself. You didn't touch something or turn around and touch something that you're now contaminated. They can help with positioning or keeping the patient from moving. Draping assistance, ultrasound assistance. They can hand you the probe so it can go down the sleeve. They can sedate if necessary, and they can watch for arrhythmias or ectopy. As the guide wire is going into the heart, okay, you can actually get all kinds of arrhythmias. Now, this is usually very benign, so you have these little short runs of VTAC. That's great. It knows you're in the right position. However, remember that if you are tickling the right atrium or the SA node or that area in somebody who has a pre-existing left bundle branch block, now you are potentially blocking their right bundle, and they can go into a complete heart block, and if you do it long enough, they may not come out of it, okay? So remember, pre-existing left bundle branch block is a dangerous caveat when you're tickling the heart with a wire. So again, and it also help you with needle count at the end of it all. So everybody knows this, right? It's the Poiseuille-Hagen formula, okay? It's the reason that, we choose our catheters the way we do. Everybody knows this, right? That this is the reason we choose the catheters that we do. I was just laughing because she knows this one. So what happens is, that's not me, by the way. Anyway, so this is the formula. So basically what it tells you is that flow, which is Q, okay, is proportional to the radius to the fourth power. So, the bigger the catheter, substantially the bigger, the faster the flow. So if you are resuscitating someone and you need to go ahead and pour blood in really fast, you want to use a big bore catheter because the flow is going to be fast, okay? So it's intuitive. If someone is in a trauma situation, you probably don't want to be putting in a triple lumen. You want to put an introducer in, okay? Or maybe a peripheral 14 gauge or 16 gauge. That's where you're resuscitating the patient really, really quickly. But look what happens here. The length is also very important. So the longer the catheter, the slower the flow, okay? So if you have a triple lumen catheter, it's much longer than an introducer, plus it's also smaller. It's going to have a very restrictive flow compared to something like an introducer and even compared to a peripheral IV. So sometimes you can get better flow in a peripheral IV because they're short, especially if you use a larger one, like an 18 or a 16 or potentially a 14 gauge if you can get one, okay? So the shorter, the wider, the better the flow. So short peripheral IV beats out a central line in trauma situations where you have to transfuse or volume resuscitate very, very, very quickly. Okay, so this is the reason we choose the catheters the way we do. How about the IO line? This has come into vogue. Okay, so all of our charge nurses, in fact, Taylor's going to be demonstrating to you how to put in an IO line. We have an IO kit right here, so she'll be showing you this afternoon how this works. And the IO is really fast access. Okay, so if you've ever seen this, most of the time it goes into the tibia. Some of the time it goes into the humerus. And if you've ever seen the DOD do it, they actually have it something they slap right onto the chest and it goes right into the sternum. Okay, that's like a 2-second procedure. Okay, so they do it in the battlefield and it's very, very fast. You can infuse fluids, vasopressors, drugs, whatever you need to give through an IO line. So again, This is how it works. It provides a non-collapsible entry point. This is not like a vein. Okay, the marrow is always there to absorb this stuff, and it links right up with the circulation. And so when IV access is not available or feasible, consider the IO line. It's really fast, and the nurses are really good with this. I think this is a skill that we all need to have. Okay, I think we need to know at least how to do this, because I know in the ICU, I think the charge nurses all do it. I'm not 100% sure if all the ICU nurses are trained. So again, this is the forum. This is the reason we came here today. So again, this is it. You use a gun, use an IO gun to access the point of entry, okay? This will be very different if you're putting one in the sternum, but we're not going to talk about that today. But you use that, and then this hooks directly up to an IV, and then that's basically, you can have your different sizes, different lengths, and then we'll talk about that later this afternoon. This is the procedure for doing it. These are all part of your slide set, and so the fact is that basically it's very simple, it's almost foolproof, but if you don't use the right length, sometimes it can infiltrate, okay? So you gotta make sure that you're fully accessed and that you're in there and it's secure, okay? The other thing about these things, you have to remember, I actually had a patient at one of the hospitals here, maybe many years back, where EMS put an IO line in, and the patient came to the ICU because they were really septic. It turned out they were having gangrene, and we needed to get vascular surgery involved. And the reason for that was because the IO that they had put in the field had somehow stayed in the patient for their entire hospitalization, about 3 weeks. So you got to remember that sometimes you got to look for these things and go through them as well, because they're not as immediately obvious as the central line. So remember, there's a bunch of caveats. The reason I'm standing here is probably because I've been burned so much, and I have a lot of old stories to tell. But anyway, so just remember, stand on the shoulders of people who've done it before. So we're moving along. By the way, look at this. So this is where we stand right here. We did access. We're going to talk a little bit about airway management, and then, boy, we're going to start moving here. Okay, so airway management, very similar. Airway management occurs when your patient can't breathe. So the patient can't breathe, why? Because they're acutely hypoxic, they're hypercapnic. Hypoxia occurs with the COVID, right? Hypercapnia occurs with COPD. They can have a chronic respiratory failure and now exacerbated, or they can be working really hard. Remember, nobody can breathe more than 30 times a minute. Okay, that's one breath every 2 seconds for any reasonable length of time, okay? The sicker you are, the older you are, the less reserve you have, one breath every 2 minutes. If you walk into a room and you see someone breathing 30 times a minute, that is a sign that patient's going to get intubated soon, unless that is their absolute total normal. We see that sometimes, but it's very rare, and those patients are really living on the edge. You walk into an acute care situation, patient's breathing 30 times a minute, get ready to think about intubating that patient. Airway protection. Sometimes you got to protect the airway. It could be a bad nosebleed, or it could be cervical spine injury or facial injuries, something like that. It could be angioedema or cervical mass or something along those lines. You're protecting the airway, or somebody who's vomiting and can't protect their airway because they're obtunded, okay? So again, in neurologic situations, you may need to protect the airway. So what do you need to do? Get ready. You need to have reversal agents, okay, if indicated, okay? So if a patient, you walk into a floor patient, it's 2 o'clock in the morning, and you get called because the patient's not breathing well and their sats really low, but they've been on a PCA, well, that's where your reversal agent comes in. Give them a small dose of Narcan, and then maybe they don't need to be intubated, okay? So think about that, okay, as you go in. In the emergency department, unlikely, but you might have a drug overdose situation. So think about reversing things that are there from before, or flumazenil for somebody who just came out of the GI suite, for example, who is not breathing very well. So Narcan, flumazenil, all these things can be very important to prevent the intubation in the first place. Clear the oropharynx. Give me all kinds of stuff in there. Jaw thrust, okay, when no cervical spine injury is, and then oxygen and positive pressure. This is what you start to get ready with, and we'll talk about these in a little bit. So this is a blocked airway. Clean out the blocked airway and just open it by doing a chin lift, okay? So there's 2 things you can do. One is the jaw thrust. This is typically what the anesthesiologists do in the operating room, and they're trained to use their little pinky, by the way, to pull up the jaw. It can be a little bit painful, but you actually do this and you slap the mask on while you're doing other things with your other hand. But the fact is, this is your jaw thrust. Now, this is, you can see, you've done a lot of mobilization of that patient's cervical spine. You really got to be careful if you're doing that in somebody who's unconscious. They have had a fall, for example, but it does open the airway very, very effectively and make it easier. The chin lift is relatively simple. This is what we're all taught to do in ACLS, and you can just go ahead and clear the airway by just lifting the tongue and the posterior soft tissues off the posterior wall of the oropharynx. So this is often just as effective as a jaw thrust. So then what you do is, do you actually go ahead and put a nasogastric tube in? I would say that if you have the time, if the patient looks like they just had a full meal, the best thing you can do is just slip a nasogastric tube in so you can at least evacuate the stomach, okay? You'll decrease the chance of aspiration very significantly. So again, do you put one in? It's up to you. And so again, that is your judgment. It is a situational judgment call, okay? So frequently we do that in the ICU. We slip a nasogastric tube in, we bag the patient a little bit, bring their oxygen up, their CO2 down, slip an NG tube in, and then it makes it a little bit easier. This, of course, doesn't project very well at all, does it? Okay, I'm sorry about that. So anyway, so mask ventilation. What do you need for mask ventilation? Remember, you could do this forever, okay, as long as someone brings you food and water. So you can bag someone for almost forever. Anesthesiologists used to give general anesthesia, and still do. We could call it mask anesthesia. It was general anesthesia without an airway in place. We would just bag the patient, and the patient would have their surgery. We would never have to actually instrument the airway. So again, what do you need? You need your personal protective gear. You need a supply of oxygen, and make sure the oxygen is on, okay? I have been to codes where I've actually gone ahead, bagged the patient, and the stats getting worse. I need to intubate the patient right away. Boom, in goes. I swear I saw the code. I swear the tube went between the cords, and what do I see is the sats continuing to drop. And meanwhile, I'm standing there with wet underwear, wondering what happened, and somebody turns around and says, but the oxygen's not on. Okay, so always make sure that your oxygen is on, okay, and this has happened to me more than once, okay, so once again, trust me, I've been there, I know, make sure the thing is plugged in and the oxygen is running at 15 liters a minute, or whatever, how much oxygen we have. I don't know, Deshaun, is that a luxury right now? But in any case, make sure the oxygen is on. A PEEP valve can get you very, very far. You can have respiratory, set the PEEP at 5 or 10 even before you start, and as long as you have a closed airway, you can actually begin to recruit lung. And we're going to talk about lung recruitment in a little bit. You can actually recruit lung while you're actually bagging the patient with positive pressure. That's why we call this positive pressure. So PEEP valve is very important. It's also important once the tube goes in, because now you've got a closed airway, you can actually start applying PEEP before the ventilator is actually hooked up. Remember, as you put someone into the supine position, the first thing they do is they lose something called FRC, which is functional residual capacity. And what happens is the diaphragm pushes right up on the chest. And you know, you see this all the time. The surgical people in the room know this because they insufflate the air. What do? The first thing they do is put them supine, and then they insufflate the belly with air. So right away, you've lost a lot of lung capacity. How do you overcome that? You use PEEP to recruit lung back up again to improve your oxygenation. You're recruiting functional residual capacity is what you're doing. So again, the PEEP valve is very, very important. The suction catheter, you've got to have one, okay? If it's a blue suction catheter, probably better. If it's one of those ones that has the little sleeve on it, maybe not so good, because you have to remember to turn it off and on. And sometimes in a tough moment, it's really hard to remember that it's not on. But continuous suction and the availability to clear the airway, especially if vomit comes up. Okay, when the patient begins to either vomit or passively regurgitate, that airway becomes flooded very quickly and you lose your view, okay? By the way, if vomit comes up or the stuff fills the oropharynx and the patient is paralyzed and they are not breathing, they're not actually generating negative pressure in their chest, chances are the vomit will not go into the airway because you've got an airlock, okay? Now, is this 100% science? It's about 50% science, okay? But the truth is that most of the time, if they do not initiate a breath, and you've done a rapid sequence induction and they're down, and you have an airway full of regurgitated or passively regurgitated or active vomitus, chances are it will not go into the airway as long as you suction it out. But what happens is, if they're breathing spontaneously, they're going to suck it right in there, okay? So airway adjuncts, you need to have some things, and we'll talk about these things, or oral airways, and prepare to intubate if needed, when needed. Okay, so this is how you put it on. You can see this guy over here. You see the tip of his fingers are real white? That's because he's squeezing pretty hard. Okay, so there's actually no blood supply going to those fingertips right now. So you got to pull it up. If you don't have a good seal, you're not bagging the patient. You're not giving positive pressure ventilation. You're not effectively moving air, okay? So, you know, you need a mask, a face mask seal, okay? Again, sometimes you may need to do this without, especially if you're doing it in a tent, but you hopefully have an oxygen supply. Continue jaw mandible thrust, assist if needed. Okay, so your assistant is there to help. And control, okay, the breathing when you need to. Okay, so what's happening is when the patient is breathing spontaneously, What you don't want to do is you don't want to start bagging the patient real hard, because if you're bagging the patient when they're exhaling and you're pushing air in and their cords are not ready to take that breath, you're going to push it all into the stomach, okay? So you're going to insufflate the stomach. So work with the patient. If the patient is breathing spontaneously, watch their chest rise, watch their stomach, and make sure you are synchronous with them so you don't inflate the stomach. That decreases the chance of aspiration, okay? On the other hand, once you've paralyzed the patient, now it's up to you. You've got that airway. It is up to you to bag that patient. And make sure you've got good air movement, okay? Because if you don't, you've got to intubate pretty quickly. Avoid gastric distension and avoid injury to the eyes. A lot of times people throw the mask on and cause eye injury, which can be a real issue, okay? Also, be very careful when I talk about this. When you talk about control when control is needed, one of the most common causes of acute demise at a cardiopulmonary situation is over rapid breathing, okay? So somebody gets an endotracheal tube in, someone starts bagging, and what happens is you do not give them enough time to exhale. Their intrathoracic pressure becomes really big, their venous return falls, and they actually go into EMD. They go into a PEA arrest because now you've overinflated the chest. And sometimes when the respiratory therapist disconnects to hook the ventilator up, you hear this long, and what's happening is that's all the air coming out of their lungs. And what they've done is we have dynamically hyperinflated their lung to the point where they have no venous return and they have no blood to pump. Remember that, okay? So the very, very important tools. So again, you want to look. What do? You compress the bag pretty well in order to move air. You watch your rate. And then give oxygen and look for leaks, okay? If it's not working, if you have somebody with a big beard, for example, then sometimes it can be really hard to get a good mask fit. Change the mask size if you need to, increase your downward pressure, use that two-handed technique. And sometimes that's really important, okay? Sometimes you are not able to do it by yourself, so you call your friend to help you, okay? In this case, you are actually managing the airway to provide a mask seal, and someone else has to come and squeeze the bag. So sometimes it becomes a two-person operation. Once again, this is so important. Once again, I keep saying it takes a team. So top 5 things about intubation. The easy ones are easy. The hard ones are hard, okay? Take it from someone who's seen both kinds. Never take an airway away from someone who has one, okay? Unless it is an emergency, you are skilled, ready, and have a backup plan, okay? These are the things you need to remember. Someone's breathing, and you're all by yourself. Probably not a good idea to intubate this patient right now if you don't think it's really safe. Wait for some help to come along. It's not a sign of weakness. Somebody else can help you. At least they can run and help get stuff if you run into a difficult airway. And there's an algorithm for dealing with that. You make sure you have backup, and the assistant is essential for this, okay? So once again, our PAs are always in the room when we are intubating, as are our nurses, okay? Nurses are frequently pushing medications. The PAs are handing things to me or Dr. Seablum. And we are working together. So this is your endotracheal tube. It doesn't project very well, but it has a couple of moving parts. One is the balloon. So once the endotracheal tube goes in, the balloon goes up, okay? And usually there will be someone there. Just push it to the point where it's reasonably well expanded. People will fix it later. This is a typical endotracheal tube. These are nasotracheal intubation tubes, okay? So these have special bends that go through the nose. If you get one of these, you can still put it through the cords, but it's a lot harder, okay? So again, you're looking for one of these, okay? Very important. So airway adjuncts, good judgment. Nothing beats good judgment. Medications, so we'll talk about that. Oral airways, nasal airways, stylets, bougies, laryngoscopes, wands, and a cricothyroidotomy kit. These are all things that you need to have in order to manage an airway, okay? So an oral airway allows you to put something in the mouth to move the soft tissue off the posterior oropharynx, so it makes it a little easier for air to move. A nasopharyngeal airway is one that goes in the nose. It's a little bit harder to tolerate when people are awake, but what happens is that also bypasses. You can get, sometimes when people are clenching down, you can put a nasal airway in if they're clenching down, and you can use that to help pre-oxygenate them before you get the tube in. A stylet really helps, especially during rapid sequence induction, because you want to get it in the first try if you possibly can. And I'll talk a little bit about a bougie and some of the other stuff. So these are oral airways. Okay, over here, these are oral airways. These are nasopharyngeal airways, and you should be ready to ask for them. This is a stylet, and this is the bougie. Okay, the bougie is actually something that sometimes you can slip through the endotracheal, through the vocal cords, and use that as your guide wire, a thick guide wire, when it's a hard intubation. Sometimes it's just, you cannot make that bend. They've got some prominent incisors or whatever. You cannot make that bend. And the bougie allows you to do that. And sometimes it goes through the cords. You slide the endotracheal tube through the bougie, over the bougie, and there you're on your way. Okay, difficult airways. Cervical spine immobility, short neck, obese, receding mandibles, large tongue, prominent teeth, a short thyromental distance. If you put your finger underneath their chin, and you cannot get 3 finger breaths, okay, between there and the thyroid cartilage, then that is a sign of a potentially very difficult intubation. Obstructive sleep apnea habitus. Some of these folks are very easy to intubate, and others are really hard to intubate. And if they have neck masses, that's another issue, okay? We use the, the pneumonic moans, mask, obesity, age over 55, no teeth, and stiff lung. This usually tells you that you will have difficulty bagging the patient. Why? Because the teeth actually help splint the airway open. And what happens is, if they're obese, they have obstructive type of sleep apnea, and the soft tissues can collapse and makes it very hard for you to bag these patients. These patients may then be very easy to intubate, but they're hard to bag, okay? So again, if you can't bag the patient and it's an emergency, the next thing you're going to do is you're going to put them off to sleep, paralyze them, and probably get the tube in. This is your difficult airway pneumonic. It's lemon. Look. Evaluate the mouth, look for the intra-incisor gap, the hyomental and the thyromental distances underneath the chin, okay, to see what kind of an airway they have. Sometimes you have time, you can do a Mallampati score. Sometimes you don't, you're just gonna have to wing it. Look for things in the neck, okay, like a big hematoma, for example, or something like soft tissue and neck immobility. That can make the intubation really difficult if you can't extend the neck backwards a little bit. So again, this is your stylet. Stylet cannot protrude from the tip. Okay, I cannot tell you the number of times people hand, especially the code, I say stylet the tube, they give me the tube and the stylet's sticking out this far. If that tube goes in with a hockey stick hook on it, it will perforate the tracheal cartilages and you will have a real problem, okay? So the fact is it cannot protrude through the tip of the endotracheal tube. That is very, very important, okay? The other thing is, you see how they put a nice little curve on it over here? That keeps you from poking the patient's eyes out. Because if you bend this back on itself and you have the sharp thing looking into the patient, what happens is as you're putting the endotracheal tube in, you can actually cause trauma to the face with the other end of the stylet if it is not secured, okay? Most of the time you're looking at the cords, you're not looking at the situation, you lose a little situational awareness, and if you're not careful, you can actually cause really bad eye injury to the patient. This is the bougie. You want to start with a little hockey stick on it. This will usually go into between the cords. It's a little bit easier to maneuver than the larger endotracheal tube. And sometimes it works also in people who have very small mouths. If you have somebody with a very small oral cavity and the laryngoscope is occupying a lot of that oral cavity, it's hard to see around the laryngoscope to see the cords or maneuver around it. So what happens is you can slip a bougie in, and now it's a little bit smaller. You can actually visualize it going through the cords and makes your intubation a little bit easier. The bougie is meant to go through, so the endotracheal tube will go over the bougie. So once your bougie is in, you can either assist it using a laryngoscope to help guide it, because sometimes it doesn't make the curve very well, or what you can do is sometimes it just goes in by itself. So there's different ways of doing that. So if someone asks you for a bougie, that is what they are looking for. It is a difficult airway adjunct. If you're going to be the first assistant, you need to know that, sometimes, like I said, folks will actually tell me, you're having trouble. Do you need the bougie? Oh yeah, didn't even think about it. Next thing you know, it's in your hands. That is the job. That is a mark of an amazing first assistant. Okay. Laryngoscopy. This is the laryngoscope. Everybody's seen one. Okay, it has a bulb. Sometimes they're fiber optic. This is your video laryngoscope, and it helps for you to go ahead and instrument the airway. There's different kinds of blades. These are Mac blades and Miller blades. Everybody has a preference. Okay, these are big. They take up a lot of room in the mouth. These are small. They don't take up quite as much room. And everybody has a preference. Some people like to start with this and go to this if they can't get it. Some people go right to this, and when they can't get it, they go back there. So again, it's a matter of preference. It depends on where you are. It depends a little bit on the situation, a little bit on the patient. But if someone's asking you for a Macintosh blade, this is what they're asking for. If someone's asking for a Miller, it is a straight blade. The other thing you got to remember is some people have fiber optic blades and some people have bulb blades, and the two are not interchangeable. So sometimes they give you a fiber optic blade onto a traditional laryngoscope and you can't get it to fit. So the blade has to match up with the actual handpiece, because if it doesn't, that could be a problem. This is one of our problems in the ICU. We actually have both. And sometimes in an emergency, people give you the fiber optic blade, and it doesn't match on to the handle. So again, this is your video laryngoscope. So again, you make sure the suction's there. You want to pre-oxygenate a little bit. What's a rapid sequence induction? Rapid sequence induction just means that you are going to move fast. Now, traditionally in the operating room, what we do is we go ahead and we put the patient off to sleep. We bag the patient a little bit. They're NPO. They don't usually have a full stomach. We pre-oxygenate them. We make sure we have an easy mask airway. Then we paralyze them. Makes it easier to get through the cords, and everything is moving along really well, okay? It takes a moment or two longer for that technique to work, but sometimes what happens is that in a difficult situation, you actually need to give them medications. In a code situation, you don't need meds, okay? So if I walk up to a code situation and the patient's, in agonal breathing, or they're, we're about to begin CPR, sometimes you don't need medications, okay? So this is very important, because I don't think this is kind of lost on some folks in the hospital sometimes. They are looking for medications, and you give medications in that kind of situation, you're going to lose the patient. So the recipe is sedation plus paralysis. What's sedation? A little bit of an opiate like fentanyl, or whatever, a midazolam type benzodiazepine, and sometimes a hypnotic. Etomidate, ketamine, or propofol are all good hypnotic choices, okay? Etomidate keeps the patient breathing spontaneously while they go to sleep, okay? It causes some problems, okay? There's actually some problems right now. I think there's an article in JAMA last week about how etomidate actually causes pro-inflammatory mediators to be released, and septic patients don't do well with etomidate. The other thing with etomidate, it actually suppresses adrenocortical system. So these people become acutely hypoadrenal, okay? So it's a little bit of a problem, usually subclinical in most patients, which makes it really nice because you can use this, they're breathing spontaneously, and you still have control of the airway. Ketamine is actually an indirect acting sympathomimetic agent. So what it actually does is it helps release catecholamines. Am I talking too fast? Yeah, I'm talking too fast, ain't I? You tell me, slow down. Okay, so what happens is ketamine actually causes, it's like cocaine. It causes release of neurotransmitters like adrenaline or noradrenaline, right? Norepinephrine, epinephrine from the nerve terminals. And what it does is it helps bolster the cardiovascular system, okay? So it can cause some tachycardia, it can actually cause some salivation, which can interfere a little bit. You have to be a little bit careful in it with patients who are already tachycardic, because you can induce a supraventricular tachycardia, and that's the thing with ketamine. But again, these two medications will keep the patient completely zoned out, but breathing spontaneously, okay? So they have a little bit of an effect. Propofol, and actually I in-serviced the entire propofol sales force when they were actually marketing propofol for ICU use. So I went to Dallas, and I was a big believer in propofol. To this day, I'm still a big believer in propofol, and I call it white death in a bottle. So you have to be very careful with it, because it is enough to take away any sympathetic tone from patients who are very sick. It's profoundly myocardial suppressant. It's a profound venodilator and arterial vasodilator. So it can actually cause this patient to go into cardiac arrest really fast. It works really fast, and it goes away pretty quickly. And a lot of people like to use it because we have it everywhere, okay? So sometimes it's the easiest thing to get your hands on. But you can crash a patient really fast with propofol if they're very sick. Propofol is wonderful in the operating room. It's wonderful in outpatient surgery, but it is not such a good drug to intubate a critically ill patient with, okay? Just remember that. It is a really fast way to crash a patient, because it is white death in a bottle for a septic patient, a patient having an MI, for a patient who is hypovolemic, hemorrhagic, any one of these shock states, they crash fast, okay. Paralytic is depolarizing succinylcholine. You've got to be careful about it in people who are hyperkalemic or potentially hyperkalemic, like burn patients or chronically immobilized patients. So we don't use a lot of succinylcholine anymore. It's sort of going away. We use a lot more rocuronium. It's really fast acting. So we used to give, it used to be about 1 milligram per kilogram of succinylcholine for intubation, or 1.5 milligrams, in that area. We are usually giving somewhere in the order of half a milligram to a milligram per kilogram of rocuronium, okay? So, 50 milligrams will paralyze just about anybody, okay? And again, you don't have to be fully paralyzed to get the tube in. Atracurium we don't use a lot, causes histamine release. People flush really fast. They get hypotensive sometimes. And Vecurome is very long-acting. We tend not to have that available. So the recipe is put them to sleep and paralyze them. That's called a rapid sequence intubation. Any questions? Too fast, too short? Want more? No. Okay, good. All righty. So these are some of the doses. Okay, this is also in your handout. Okay, so fentanyl, usually we're giving it in 25, 50, 100 microgram boluses. Okay, again, these are some of the micrograms per kilo boluses. So 50 micrograms gets you a very light sedation in most people. Older people can be very sensitive to that. The same is true with Versed. Okay, you combine the two, you have synergistic cardiovascular depression. Very important to remember. You can give fentanyl, which is really, let me tell you about fentanyl. When I was a cardiac anesthesiologist, I was doing cardiac anesthesia at the University of Rochester, we used to pull up 60 cc syringes of fentanyl. 60 cc syringes of fentanyl, and we would give most of that fentanyl to a typical patient who came in for emergency heart surgery because it was so incredibly hemodynamically stable. Of course, they'd be on the ventilator for 4 days, right? So that wasn't called fast tracking. But the thing is that those were the ways that we used to do cardiac anesthesia because it does not cause hemodynamic instability. So you can get away with a lot of fentanyl, but you add a little Versed, boom. That's a double whammy, and it is now synergistic cardiovascular and respiratory depression, okay? Etominate, this is it. Usually you're giving somewhere in the order of maybe 8 milligrams to about 20 milligrams for a typical person. Depends a little bit on how robust they are, and you give it as a single bolus, okay? Lidocaine, some people like to give lidocaine before they intubate. Usually we do that only with head patients. So I do that to minimize airway irritation or sympathetic surge in somebody who has a head bleed, an aneurysm, or intracranial hemorrhage. Ketamine, again, you can give it in usual doses. This is also per kilogram, so a milligram to 4 milligrams per kilogram IV bolus will get you a pretty good hypnotic state. The funny thing about ketamine is they will be breathing on their own, they'll be salivating, and they will be looking at you, and you think to yourself, no, this guy cannot be asleep. But the fact is, they are out cold. We have done exploratory laparotomies in the ICU with ketamine alone, and the surgeon's hand was this far into the patient's belly, and they were breathing spontaneously. And then we realized the anastomosis broke down, so they went to the OR. But while we did all this stuff, the surgeon was looking around, and yep, it's pure ketamine, and they don't remember a thing, okay? So again, it is a very valuable tool under certain circumstances, but again, it will potentially cause tachycardia, and it can also help to support the circulation in people who are hypovolemic. And propofol is a milligram to 2 milligrams per kilogram bolus, usually somewhere in the order of 50 to 100 milligrams for most people will do the trick. So again, be prepared for the crash, okay? Be prepared for the crash. This is not a joke. When you go ahead and you take away the sympathetic tone of someone who has been living on sympathetic tone, and they are in pain, and that is, they're having difficulty breathing, they're all worked up, and all of a sudden, you take away that tone, you take away the catecholamine surge, they will crash. You take someone who's hypovolemic, you put them on positive pressure, they'll crash even more, okay? So now all of a sudden, you got the airway, but now all of a sudden, you're coding the patient. So be very careful. Sometimes judicious, less is more is better, okay? Because preparing for the crash is not a joke. So you got to be prepared for how you're going to rescue someone from the crash, okay? So how do you do this? You get a bolus ready. And frequently that's enough. You position patient head down. A lot of times patient's blood pressure is 70 over 20, and they're still sitting up at 45 degrees. Okay, that's a good idea not to do that. Okay, maintain perfusion to the brain, and also let the heart fill back up. Okay, and put their head down if you possibly can. The airway's already secured, and you can actually cause some venous filling back into that right heart. Medications: ephedrine, indirect acting sympathomimetic. Okay, precursor for crystal meth. Right, that's why it's controlled now. But the fact is that you give it in small boluses, 5, 10, 15, 20 milligrams, and what happens is it causes release of catecholamines. It doesn't cause a huge bump in your heart rate or your blood pressure. It's just a very slow incremental way of getting there. If it's a real emergency, you won't be using ephedrine. Norepinephrine and phenylephrine are also adjuncts, and sometimes it does get to that in the ICU when people get intubated. So how can you help? You hand things, put things into people's hands, know what comes next, keep an eye on the monitor. Sometimes you put the tube in and the patient, just by the act of laryngoscopy, they'll go into a vagal arrest, okay? You know that because people get nauseous, they go into vagal arrest. So again, just keep an eye on the monitors, so your first assistant should be watching the situation, okay, while you're focused on that airway, because you can't be watching everything, okay? Got to trust your people, have good people at your beds, at your side, and things will go better. So help secure the tube, take care of orders. So check, and recheck. How's the tube in good position? Tube's in good position if you saw it go through the cords, probably, okay? We use a sustained end-tidal CO2, okay? The first end-tidal CO2 you get with the litmus paper test is sometimes falsely positive, okay? For example, okay, somebody had a Diet Coke before they came in, and now their stomach's full of carbon dioxide. You intubated the stomach. Ooh, look at that. Now the carbon dioxide's coming back. I feel good about this. Walk away and it's not so good, okay? So it is not a foolproof test if you only get one. That's why more and more we're using like the Barneys and things to verify the endotracheal tube placement, especially during difficult intubations. So sustained end-tidal CO2. If you go ahead and pre-oxygenate someone really well, also known as denitrogenation, you pre-oxygenate, you got the mask on, you're pre-oxygenating for a rapid sequence induction, and they have pretty healthy lungs, okay? So anyone in this room probably. I put the endotracheal tube, I paralyze you so you can't breathe. I put the endotracheal tube in your esophagus. You will have a really good sat for about 6 minutes. Okay, it's long enough for me to make it to the cafeteria and buy myself lunch, okay? And then I'm gonna get a stat page back to the ICU saying, oh, the sat's dropping and patient's crashing, okay? So that amount of oxygen will keep the patient sat up for a long, long time, okay? Sick people, not so long, okay? But still, you can be fooled because the sat looks really good for a while. It takes a little while for that oxygen to be absorbed from the lungs after you've been masking them. But now, all of a sudden, the tube's in the stomach, okay? So that's a big deal. So remember that sustained end-tidal CO2 is really good. So breath sounds, well, sometimes you hear them, sometimes you don't. So it's a penny in the well. You kind of wish and hope, and yeah, I think it's there. And then what happens here is chest x-ray, sometimes it's too much too late. I know how to spell tube, but it was dark. And so what happens is, rules out endobronchial intubation, and it's also medically, legally important. Okay. So this is your end-tidal CO2 one-time litmus paper test. It looks for the carbon dioxide, turns into acid, turns yellow. This is your sustained end-tidal CO2 monitor. This is actually a capnograph combined with a capnometer. So you know what the end-tidal CO2 is, and you can look at the waveform pattern, okay? Very, very useful tube, very adjunct after getting the endotracheal tube in. Secure the tube in position. Do not leave the head of the bed until the tube is secured and people tell you that it's okay to go. Sometimes they're securing the tube, the head turns, something happens, the tube falls out, okay? Just make sure the tube is secured before you walk away. This is your endotracheal tube. That's in good position there. It's a little bit past the clavicles. Here, you can't see it so well. I hope you can see it. But this is the carina here. So you want to be about 2.5 centimeters above the carina, and that's a good place for you to be. So about midway between the clavicles and the carina, okay? Here you have an endotracheal tube that's down the right mainstem bronchus, okay? So you're ventilating this lung over here, but you can see that this lung's already starting to have atelectasis by the time they chest x-ray, so that's an endobronchial intubation. You wait long enough, this lung will completely collapse down upon itself and it'll be white, and this lung here will be overinflated, okay? And you can actually damage the good lung by overventilating it with large tidal volumes, which that lung is not able to take. So in a typical adult female, somewhere about 21 to 22 will give you perfect position. In an adult typical male, somewhere about 22 to 23. Sean? Pretty close, okay? That'll give you a good starting point. Remember, once you take the x-ray, you can always reposition it, pull it back, or push it in a little bit more if you need to, but that'll be a good starting point. Those are good numbers to remember in the back of your head. Any other questions? Points? Fine points? Okay, so here we go. Sedatives, we talked about this. Propofol, benzodiazepines. I'm just going to let you review this on your own. So where we are now is 20 to 12, and we are in, yeah, we're there. Okay, where we're supposed to be. Management of shock. Okay, we're going to get through this, and probably we'll see how things go, and then we'll break for lunch potentially, because there's a lot to know about shock. I'm still learning. I mean, it's really horrible. After all these years, I'm still learning about shock. It surprises me every day. So the thing is that what the problem with shock is that it's inadequate substrate delivery to meet the needs of tissues, okay? So you can have shock from decreased oxygen, you can have potentially hypoglycemic shock, but again, that's a slightly different kind of shock. We're not going to talk about that today, but it's basically substrate delivery to the tissues. Most of the time when we talk about shock, it's blood flow and it's oxygen. Those are the two things that we're looking at. There are different kinds of shock, okay? And I have a couple of slides on this, so I'm wondering which is the best way to do it. There's 4 types. There's distributive shock, which includes things like anaphylactic, neurogenic, septic, and hypoadrenalism, and a couple of others. Cardiogenic shock is what we see in the CT, ICU, or the CCU when somebody has pump failure and their heart isn't working anymore. Hypovolemic shock could be hemorrhagic or dehydration. Interestingly enough, distributive shock causes a little bit of a hypovolemic shock because they're so vasodilated. So it's not a pure distributive situation. It's actually a little bit hypovolemic as well. And just kind of remember that because, nobody here is taking boards on this. But again, that's how they behave clinically, okay? So I would never say this to students in a room, but I would say that most shock that is septic shock or even anaphylactic shock, those people are vasodilated, and because they're vasodilated, they need preload, so they behave as someone who's hypovolemic. Okay, so don't write that on your boards. You never heard it from me. Okay, obstructive shock is things like restrictive pericarditis, tamponade, pulmonary embolism, something like that, for example. So I don't know how that got there. Okay, I am going to move through shock. Okay, the golden hour. The golden hour is really the golden hour, okay? So you have the longer a patient's in shock, the more likely they will die, okay? So remember that. You do not have a lot of time to play around with shock. As you go, and I will show you this with multiple slides, I'll say it over and over and over again, the longer the patient is in shock, the more likely it is that they will die because those tissues that are not being perfused are going on to develop multiple organ failure. And that multiple organ failure will cause activation of the cascades, the cytokine storm, that will then cause that patient to go bad, okay? So it's the double hit, okay? So get on shock really early. So again, it's an incontrovertible truth. The frontline performance, the stuff that gets done early on makes all the difference, okay? And, the PAs in the ICU are so good about that. They get called to a patient in the emergency department. They got lines in, they got fluids running. We got the whole, the situation starting to evolve very, very quickly. We're getting phone calls, and we're moving the patient out of that arena into a new one. Because, again, the longer the patient is in shock, the worst thing you could do is let someone sit there and basically percolate for a while, okay? Because that will do no good to anybody, okay? So again, knowing what matters, okay, communication. Okay, we talked a little bit about that. Dr. Herman did an amazing talk on that. So know communication through the lines of the system. Make sure the nurses know what's coming in, okay? Make sure the providers know what's coming in. Respiratory therapy, if they need to get the ventilator. Make sure everybody knows what's about to run through the door. Document the severity. I like this, okay? Because you know what? When they leave one arena and go into another one, you don't really have a sense of where they left out, okay? How bad was the belly? How bad was the blood pressure? And then know the phases of care, resuscitation, monitoring, and standards. So know what matters, okay? Have a strategy. Here we go. Here's the strategy. Here's the funny thing about strategy. You can have a patient who has a perfect set of numbers. They have what we used to call Harvard numbers, okay? And what happened, they had Harvard numbers, but they were going south anyway. And, those of us, who were doing rotations at BU couldn't figure out why Harvard patients or Harvard numbers would be going south. Well, the problem is we look at the big scheme. The big scheme is a pulse oximeter, the blood pressure. Everything looks good. The patient's in shock. And we have a name for that. What do we call that? Called compensated shock, okay? Compensated shock is a really bad place to be. It means your tissues are underperfused. Maybe you stopped making urine at midnight. Okay, maybe you're starting to look a little mottled, okay? And maybe you're starting to look a little confused, but your pulse oximetry, your heart rate, everything else is still fine, okay? So you're in this compensated shock where everything looks really good, but if you actually look at what's happening at the cellular level, the tissues are going to shit. I'm sorry. So what happens is tissues are going bad, okay? So what's happening here is that the cellular oximetry, when we used to measure cellular oximetry, and we still do it in an experimental model, those tissues are starving for oxygen. They're releasing cytokines. The tumor necrosis factors, the interleukins, they're leaking out of the cells, and you're starting to see all the beginning signs of shock. This is so important when we talk about COVID, because you've got that kind of time where a patient's looking pretty good, but they're starting to fall apart. And it's the subtle indicators, okay, for that compensated shock that are the clues, and sometimes it takes a little bit of experience to pick it up. We'll talk a little bit more about that. Remember, stay away from not knowing that you don't know. That's the important thing. So we talked a little bit about this already. This just makes it nice. So these are different kinds of classification of shock. And again, distributive and hypovolemic shock tend to go together. So what happens is, how do we classify this? So cardiogenic shock has a low cardiac output. The CVP is usually high because the pump isn't working. And the systemic vascular resistance is really high. So these patients are clamped down. And what happens is everything gets worse because their systemic vascular resistance is high. That's further depressing the cardiac output. So again, what happens here is, the mixed venous oxygen is really low because they're extracting all the oxygen that they have in the tissues. So think about this, as your little box cars on your little railroad set are going really slowly past the cells. And when they're going really slowly past the cells, all the oxygen is coming out of the red cells. So they're maximally extracted, so the mixed venous oxygen tension is really low, and what happens is you're maximally extracting your oxygen. So these patients are going into shock, because every go-around, those cells are getting loaded up with less and less, okay? So the tissues are getting into more and more trouble. In hypovolemic shock, your cardiac output's low because you have no preload, okay? Here it's pump failure. Here it's a drop in preload. That's the filling pressure of the right heart. So what happens is you have no filling pressure. These patients are really, really clamped down, and this is when we see things like livido reticularis, mottling, okay? You look at the knees. Sometimes people wonder, go in the ICU, look at everybody's knees first. The thing is not that I have a thing for knees. The knees are the canary in the landmine, okay? Or the mine. And what they will tell you is that they will show you that the patient is underperfused. They can still sometimes feel warm, but you look at this livido reticularis pattern, goes along with that. What also goes along with it is confusion. They're starting to get acutely agitated or confused. The brain isn't getting enough oxygen either. So what happens is the systemic vascular resistance is really high, and these patients are also maximally extracting. So here you have distributive shock, which is your typical septic shock, okay? So here you can be high or low depending, okay? And this is depending because early on, they have no systemic vascular resistance. And what happens to these patients is they're vasodilated, so there's no impedance to left heart cardiac output. And with that no impedance, their heart is able to pump real high, so they're in a hyperdynamic shock state. You give them some time and don't resuscitate them, then their systemic vascular resistance goes up. That's when they crash, okay? So if you get on top of them, they will not have a drop in their cardiac output. Their filling pressures are very low. They're kind of like hypovolemic. Systemic vascular resistance here is usually low. Once again, they're all dilated out, and their mixed venous oxygen saturation is high because the hyperdynamic red cells are zooming past the tissues. So unlike the cardiogenic shock where they're going real slowly past the cells, these guys are going fast. There's not enough time to extract the oxygen, okay, because they're so hyperdynamic. Does that make sense to everybody? Okay, so if some of this stuff is probably reviewed to some people, and some people are probably have never seen it before. If you haven't seen it before, just put your hand up and just ask me, okay? So again, I don't exactly know where to go with some of this. So you're at a community hospital, a patient presents with a cough. They have some problems. They come with a blood pressure of 78 over 35, a heart rate of 147, a SAT of 89, and that's on a non-rebreather, and the respiratory rate's 32. How sick is this patient? Obviously sick, okay? So again, you start looking, you start probably going to have to intubate this patient, right? The respiratory rate's greater than 30. Their blood pressure is really low. So how many people here would start with a vasopressor? How many people here would start with fluids? Okay, that's the way to go, okay? So they're probably got a compensatory tachycardia for a profoundly hypovolemic state. They're not oxygenating well for one of many, many reasons, and they're in respiratory distress, okay? So they're hypoxemic respiratory distress. So their white count's 1.5. 38% bands, and they have this thing called vacuolization and Dole bodies and toxic granulations. So what does that mean? Anybody ever look at the differential to see that stuff? It's at the bottom of your differential. Perfect, okay? These things are clues that this situation is not good, okay? If this white count was 8 and they had 38% bands, the situation would be just as goodly bad, okay? Exactly. So what happens is, no matter what, this 38% bend is what's telling you this patient's bone marrow and their lymphatic system and their lymphopoietic system is stressed out to the max, and they're pumping out white cells so fast that they're immature. Okay, it's like graduating the medical students now, kind of thing, right? So the fact is, the fact is you're pumping them out too fast. Okay, so the thing is, so this bandemia and this toxic granulations, vascularization, these are all indicators that the patient is maximally stressed. Okay, so this is a bad place. So your lactate comes back at 5.2. Is that a good thing or a bad thing? Very bad thing. Okay, so you got a pretty high lactate level to begin with. Okay, so your next steps we already talked about a little bit. Okay. So suppose I tell you the patient's been in the ED for 3 hours. He presented with dyspnea, a little chest pain, got some Lasix on arrival. He put out 100 cc's of urine. He passed, otherwise prior peed 6 hours. He got this because he looked like he was in a little heart failure, so they gave him a little Lasix, okay? And they thought it might help him a little bit because he had prior MI, right? So you're thinking pump failure. Okay, the labs are 3 hours old, okay? Patient's gotten 2 liters of crystalloid. They come back with a pH of 7.12 and a bicarb of 12. Okay, where are we going? What does this tell us? Yeah, they're basically like getting ready to die, okay? Below a pH of about 7.15, cell receptors cannot respond to catecholamines. You put the patient on a norepinephrine drip, it doesn't work so well. Put the patient on an epinephrine drip, it doesn't work so well. There's changes in the configuration of the receptors. So patients in big trouble, they have a profound metabolic acidosis. Thankfully, we got some Zosyn already, okay? So the thing is, on we go. So we talk about sepsis bundles. I'm not going to spend a lot of time on this, but there are ways to clue things in. The first, what's a bundle? These are things that we call best practices. I'm not going to spend a lot of time on best practices, but you must complete within 1 hour, you get a serum lactate level. If they did it, they got some blood cultures prior to antibiotics. I hope so. And then what happens is they're treating hypotension and elevated lactate with a lot of fluid. 30 mLs per kilogram. So you have a 70 ml kilogram, that's a lot of fluid, okay? That goes in really fast, okay? And then you start vasopressors for hypotension if it doesn't respond with a MAP of greater than 65, because that's what most people need to perfuse tissue, right? So remember, if you're talking about mean arterial blood pressure, if you talk about coronary artery perfusion pressure, it's your mean arterial pressure minus your left ventricular end diastolic pressure. If you're talking about cerebral perfusion pressure, it's once again your mean arterial blood pressure minus your ICP. So you see how mean arterial blood pressure is really important? It keeps everything alive, okay? So this is fundamental. You got to get the mean arterial blood pressure up really fast, and usually with fluids first, because if you don't, the patient's in shock for a long time. So what happens is we're going to talk about this formula, which tells us a lot. This tells us about how oxygen gets to the tissues. It's delivery of oxygen, DO2, okay? This is so much fun, but it's going to tell you a lot. It's going to probably change the way you look at the world, okay? It's a big promise to make, but it's true. If you think about this, arterial oxygen content is basically what's in the blood and how fast it's moving, what the motor's doing to move the blood around, right? So if you have X amount of oxygen, but we're moving it really fast, that's good oxygen delivery. If you have X amount of oxygen, but we're moving it really slow, that's bad oxygen delivery. On the other hand, if you're moving no oxygen around really fast, that's no oxygen delivery either, right? So there's a lot of permutations and combinations here. So you have to look at the bound oxygen and the dissolved oxygen together, and you multiply that by the cardiac index. How do you define this? It's your hemoglobin concentration times the saturation of that hemoglobin, right? So this is your SAT, plus what's dissolved in the blood, which is basically your PO2. By the way, according to this formula, what's more important, your SAT or your PO2? Your SAT, right? Okay, because this is a really small number, right? You're multiplying out 0.03, 0.003. So the thing is that that's a very small number, and this is a correction factor for your SAT because each gram of hemoglobin fully saturated carries roughly about that amount of oxygen, right? So you multiply that by your stroke volume index times your heart rate. So your stroke volume is really dependent on 3 big things. It's your preload, it's your afterload, and it's your contractility. People who have no contractility are in cardiogenic shock. People who have no preload are in hypovolemic or distributive shock, and people who have too much afterload are usually people like, for example, in neurogenic shock, okay? They can be vasoconstricted. It depends a little bit on the presentation, times the heart rate, okay? So again, this is how you sort of factor this whole thing together. And oxygen delivery to the tissues is so important because we're talking about shock. So how can I fix things? I can give blood if the blood's low. I can increase the amount of oxygen to saturate the hemoglobin and increase the PO2, but I can also work on the heart. I can work on the heart by bumping fluids in and increasing their preload, or I can give them an inotrope and increase their contractility, okay? So there's ways that I can get into the situation here. I can start to improve this patient very quickly by keeping this little algorithm in my head. I have 5 ways right off the bat that I can treat shock, right? So let's see, tissue oxygenation. What happens is oxygen delivery and oxygen consumption defines your oxygen balance, okay? So here we are. Your cardiac output is important. Your oxyhemoglobin saturation, your hemoglobin, and your PaO2 are all very, very important determinants of oxygen delivery. So this is where we go with this. So what happens if we have, here we have oxygen delivery. We are at stage 1. We are perfect. Okay, what happens here, ATP supply, remember I talked to you about the high energy currency in the body is ATP. Here it is, the supply is equal to the demand, or maybe even supply exceeds demand, okay? And here what happens is you've got, some redistribution of blood flow, everything's fine. Oxygen delivery starts to fall. It's still okay, but you've got some recruitment of capillaries, you've got some shunting, and now you're starting to get toward the inflection point. Now your supply is less than your demand. You're in a situation where you do not have enough oxygen. At the tissue level, it's not the basic SAT, it's not the PO2, it's the tissue level. And what happens here is you start to go into anaerobic metabolism, you start to have leakage of your membranes depolarize, calcium goes in, your membranes rupture, you have apoptosis, you have cell death. This is a situation where the tissues are starving for oxygen, and they start to starve for oxygen way up here, even before you really got into anaerobic metabolism. So the thing is, you've got this compensated shock that's occurring, and you've got to be careful to recognize that. So here's what happens. As your oxygen delivery begins to fall, it's going this way. Delivery, it goes up that way, comes down this way. Your oxygen delivery is dropping. You get to this point. I don't know where the point is. Nobody knows where the point is. Everybody has a different point. But what happens is you get to this certain point. And at this certain point, this is your critical oxygen delivery threshold, at which point you start to develop lactic acidosis and you develop cellular hypoxemia, or cellular hypoxia. I misspoke, hypoxia. So what happens is you have cellular hypoxia, and at this point you start to go into anaerobic glycolysis. You start to generate lactate inside the cells. The lactate is your biomarker for cells that are starving for oxygen. You can measure it, and you can start to fix it. So once you've got lactic acidosis, what are you going to do? Yeah, go back the other way, right? You figure you went down the wrong road, so you go back the other way. Here you go back this way. You increase your oxygen delivery to get yourself out of this lactic acidosis place where you don't want to be, okay? So this is how you're treating shock. So what happens is lactate is really important. It's a biomarker for bad things. It correlates with the extent of tissue ischemia. Non-perfused tissues, by the way, may not release lactate. You got a dead leg, might not show up on your lactate level. The higher the lactate, the greater the ischemia. The greater the ischemia, the greater the inflammatory trigger for MODS. So if you look at the probability of survival, if you have a lactate level of about 8, your probability of survival is somewhere about 5%, okay? So this is a really important biomarker. It helps you to stratify people into, how sick they are, okay? So once again, lactate is correlated with prognosis. I'm not going to go into this. But again, the higher the lactate level, the more poorly people will do. However, even with bad lactate levels, there's still hope. Okay, so hope is really important. And here's the hope slide. The rapid clearance of lactate. Somebody comes with a lactate of 8, and 3 hours later, the lactate's normal. It doesn't matter what it was when they came in. Okay, the faster you can clear the lactate, the better you've done for that patient. Okay, so what happens is rapid clearance means that the tissue ischemia is now controlled. So what happens, it also means that liver shock, because most of the lactate is actually extracted in the liver, has been avoided. Liver is very sensitive to hypoperfusion, and when you get transaminitis, then that's a sign that maybe the lactate levels aren't being cleared very well. It may not be that it's still being produced, That's not being cleared. So what happens is if you can clear that lactate, you've done two good things. You've increased your delivery, and you've maintained optimal clearance. Everybody understand? Got it all? Okay. Am I talking too fast? Okay, good, because sometimes I do that. So classification of lactic acidosis, there's type A, which is the tissue hypoxia type, and then you've got the type B, which you get with things like metformin. Okay, so people come in on metformin, they got lactic acidosis. It's not necessarily hypoperfusion. It can also be like things like linezolid. Propofol causes the same thing, right? This is propofol infusion syndrome. So again, but it could also be liver failure or malignancy, and you can help cure type B lactic acidosis pretty quickly with a dose of thiamine. Give them 500 milligrams of a loading dose of thiamine, or give them 100 milligrams. I mean, Kristen, is there any limit to the dose of thiamine that I've used in the eye? There you go. So the thing is that really, that's how it goes. So this is your sepsis resuscitation bundle. Now what do you want to do? You want to go ahead and give fluids. How much fluid? As much as it takes. So you want to give fluid. So here is your classic Frank-Starling curve. Oh, 5 minutes. Oh. You have food. What do you want to do? 5 minutes, wrap it up, and we'll go. Okay, that sounds good. Okay. So until your heart rate drops, your blood pressure improves, your blood pressure narrows, okay, your pulse pressure narrows, your pH improves, the urine starts to flow, mottling goes away, confusion improves, your lactate improves, the patient's in CHF, or you feel happy, okay? What's easier to fix, by the way? Renal failure or congestive heart failure? Yeah, CHF, a lot easier to fix. Don't worry so much, okay? You push it over a little bit, you'll get over it, okay? You always can find that sweet spot somewhere. So you give fluid challenges, because as you give fluid challenges, you increase your preload. The Frank-Starling curve tells you that this is your cardiac index, your ejection fraction, your cardiac output, whatever kind of indicator of cardiac function you want to use. The more you increase your preload, you get to the point where you can recruit preload, and then here, now if you go over the edge, that's when you're for sure going to have congestive heart failure. But here, at this point, you're still recruiting preload. So cardiac function is improving. Oxygen delivery is improving while you pour the fluids into the patient. Yes? Open it. Open the belly. Open the belly soon. If it's an abdominal compartment syndrome, call your surgeon. How do you diagnose abdominal compartment syndrome? High peak airway pressures, decreased urine output, full belly, reason to have an abdominal compartment syndrome, and the belly needs to be opened, right? So sometimes we check the bladder pressure. Sorry, Sam? More than 20? Yeah, 20, 25, somewhere around there, yeah. Really what happens is that tissue perfusion, capillary perfusion pressure in most normal people is about 18. So that's what capillary perfusion pressure is. Once you technically get above capillary perfusion pressure with an external pressure, you're compressing capillaries. Once you're compressing capillaries, you're causing ischemia. So some people will say 20, some people will say 25. There's also grades of abdominal compartment syndrome grading. So there's stage 1, 2, 3, I think it is, maybe 4, I can't remember. So again, but you've got to decompress. And that's very important, Vic. Thank you. So again, this is a disappearing IJ. You push on the IJ, you try to put your central line in. You can't see the IJ, it's a sign the patient's hypovolemic. Choice of resuscitation fluids, probably crystalloid, okay? We don't have a lot of colloids here. So what you're trying to do is you're trying to fill up your capacitance vessels, so that once you fill up your capacitance vessels, you've got enough flow, and you can study this later. I'm not going to spend a lot, I can spend an hour on this, but the truth is, once you've filled up your capacitance vessels, that capacitance vessels will spill over into the right heart. They'll fill into your right atrium where your CVP is measured, or you fill into your right ventricle where, basically your right ventricular preload is optimized, and then it'll push it into the left atrium and the left ventricle, so you're improving cardiac output. Okay, so the idea here is to fill up, because now you've got leaky capillaries, you've got capillaries that are vasodilated, arterioles that are vasodilated, and there's a capacitance vessels have opened up in distributive shock, and you've got to fill up that incredible capacity that has happened in the shock state. Okay. Tia, you tell me when 5 minutes are over, because I will never know. So the thing is, how do you control this? Okay, last slide. Okay, fair enough. Preload, afterload contractility, and then you can start to manage the systemic vascular resistance. I will tell you how this is, once again, goes into the notion of blood pressure. Following the blood pressure in a shock patient is misleading, especially because it's compensated shock. They look good, they're not good, okay? You have here blood pressure is flow times resistance, okay? That's, is that Ohm's law? Anyway, blood pressure is equal to cardiac output times systemic I don't know if I can think fast enough on my feet anymore. So anyway, so cardiac output times systemic vascular resistance. This is preload, afterload contractility and heart rate. And this is your systemic vascular resistance. This is your central sympathetic outflow, your alpha receptors, your glucocorticoids, your vasopressin resistance vessels. So if you know that blood pressure is cardiac output times systemic vascular resistance, if your cardiac output goes down, right, and your blood pressure stays the same, your TPR, your peripheral resistance, your systemic vascular resistance, your total peripheral resistance has to go up. They're modeled. So what happens is now if you drop this, you will improve your cardiac output, okay? Again, these are reciprocal relationships. So in order, some people can look really good with a great blood pressure and they're fully compensated. Do not believe the patient is doing fine on their blood pressure alone, okay? They can crash in a heartbeat, okay? That's my last slide. Go for it. Lunch. And we'll have half an hour for lunch, so maybe until 12:30-ish? Okay, great. Sure. Learning something? You just look.